This is Emma Cluck recording.
My name is Hannah Ellis, and I will be performing the IV administration through a central line. Hi, Mary. My name is Hannah. I'll be your student nurse today, and I will be giving you your hydromorphone because you were in pain. Can you please state your name and date of birth for me? 5/1863. Perfect. All right, I'm going to provide for privacy. Wash my hands here. I have checked my order. I have an order to give Mary Smith hydromorphone, 1 milligram IV push every 3 hours as needed for pain. I was told by the CNA that she's rating her pain an 8 out of 10, so I'm coming in to give her this medication to help with that, and she has not had it in the last 3 hours. So I see that she's an allergy for morphine. Mary, is that the only allergy you have is to morphine? And she says yes. All right, and you understand today what I will be doing is I will be giving you hydromorphone through your IV right here, and it shouldn't hurt or anything, and she understands, she knows what's going on. All right, so I have my saline flushes here. They are not expired. I'm going to go ahead and get the air out of them just to make sure that we're not giving any air through the PICC line. My patient has a PICC line because she has chemotherapy treatments that she goes through. It is not a heparin lock PICC line. If it was, I'd make sure to check my agency protocol to ensure that I'm pulling that heparin out before giving any medications or flushes. And my agency protocol is to flush with 10 mL of normal saline before and after medication administration. So no air in there. And no air in this one. All right. So now I'm going to go ahead and get dose accurate. My medication is not expired. I have hydromorphone 2 milligrams per 1 ml. I have done my math, and I know that I have to give her half of a ml in order to be dose accurate. So I'm going to go ahead and do that. If I were in a hospital setting, I would have a waste bin that I would be using probably outside of the room to ensure that nothing happens with the medication. So I'm going to push to half of a ml. Alright, so I do have half of a ml here of the hydromorphone. Alright, so now that I have my half of a ml drawn up, I'm going to go ahead and do my 5 rights 3 times. So I have Mary Smith, I have hydromorphone, 1 milligram, which is equal to the half ml, so I have half of a ml. IV push every 3 hours as needed for pain, and she has not had this in the last 3 hours. So I have Mary Smith, hydromorphone, 2 milligrams per 1 ml, which is equal to a half ml for the 1 milligram IV push every 3 hours as needed for pain, and she has not had that in the last 3 hours. Alright, I have Mary Smith, hydromorphone, 1 milligram, which is equal to a half of a ml, IV push every 3 hours as needed for pain, and she has not had this in the last 3 hours. So now that I've done my 5 rights 3 times, I'm going to go ahead and doff these gloves, wash my hands. If my patient had any IV fluids running, I would make sure that my medication is compatible, but she doesn't. And I will not be diluting this medication as it is a pre-filled syringe. I'm going to go ahead and assess my IV site for any redness, ecchymosis, edema, drainage, and approximation. Just make sure there's no phlebitis or anything like that going on, and it looks good, so I will be good to give the medication. So I'm going to go ahead and clean my line for 15 to 30 seconds. I'll let that dry, of course. My patient is understanding what's going on. If I did have a pediatric patient, I would want to have their parent or another nurse distracting them on the other side of the bed just so they don't feel intimidated or scared with me hovering over them for the time of the infusion. If I had a clamp on this line, I would unclamp and go ahead and push the saline. My IV is patent, so I'm okay to give the medication. All right, go ahead and take that off. I'm gonna go ahead and clean one more time. 1, 2, 15 to 30 seconds, watching the clock. Let that dry. And I'm gonna go ahead and get my medication. I have, in fact, researched my medication with my med handbook, and I know that I can give this medication over 2 to 5 minutes safely. During that time, I'm going to assess my patient for any hypotension, bradycardia, respiratory depression, nausea, any sedation or anything like that, and she understands and she knows to tell me if she's feeling any of those things. So 2 to 5 minutes. But for video purposes, I'm going to go ahead and push. Okay, my medication is administered. Because this is a peripheral line, I know that the line is longer, so I'm going to want to use my last saline flush here to push the first 5 mils at the accurate infusion rate of the hydromorphone. First, I'm going to clean, of course, for another 15 to 30 seconds. Go ahead and let that dry. So the first 5 mils, I will push at the accurate infusion rate of the hydromorphone for video purposes. I'm going to go ahead and push. The last 5 mils now, I am going to want to use the pulsation technique. Because this is a peripheral line, make sure that we're causing some turbidity in that line and there's nothing left in there. 1 mil at a time usually. All right. I would check my agency protocol to see if they wanted any CHD or alcohol impregnated caps attached to the peripheral line. My agency protocol is to clean with alcohol at the end of any usage of this line. So I will do that for another 15 to 30 seconds. My patient tolerated it well. She did not have any signs or adverse reactions at all. I will reassess her pain in about 30 minutes to an hour, make sure that it's working. I would throw away all my garbage, wash my hands, make sure my patient is safe and comfortable, and I would document that I gave Mary Smith 1/2 milliliter of hydromorphone at 12:07 on September 8th, and that she tolerated the procedure well.